Yeah.
I'm getting it.
Oh, we're live on right now, so. Good evening and welcome to yet another COVID-19 Conversations session 14. Our talk today will be on COVID-19 and diabetes. November is considered Diabetes Awareness Month. As usual, I am your co-moderator, Dr. Maya Williams, and also joining me is Dr. Alison Myers. To date, there are over 47 million coronavirus cases in the world, of which there are over 1 million deaths and 33 million individuals have recovered. In the United States alone, there are over 9 million COVID-19 cases, of which 236 deaths and 6 million have recovered. The CDC has reported COVID-19 within the cases with deaths in the last 7 days being over 5,000. Total cases as reported previously was over 9 million and total deaths over 230,000. COVID-19 is taking the lives of Black and Hispanics aged 18 to 49 at rates greater than for whites or Asians. What do we know about COVID-19 as per research and in the media? Associations of type 1 and type 2 diabetes with COVID-19 related mortality in England shows that the results of this nationwide analysis in England show that type 1 and type 2 diabetes were independently associated with a significant increased odds of in-hospital death with COVID-19. In terms of pre-admission diabetic specific risk factors for mortality in hospitalized patients with diabetes, the researchers analyzed the association of mortality with hemoglobin A1C levels, outpatient diabetes treatment, and other outpatient characteristics in a large cohort of hospitalized patients with diabetes and COVID-19, and importantly found that hemoglobin A1C was not predictive of in-hospital mortality. We also found that insulin treatment and obesity was strongly and independently predictive of mortality. On a study with metabolic syndrome and COVID-19 mortality among Black patients in New Orleans, the researchers found that in predominantly Black patients hospitalized for COVID-19, the clustering of hypertension, obesity, and diabetes increased the odds of mortality compared with these comorbidities individually. So what do we know about COVID-19 and diabetes? Persons who contract COVID-19 can develop new onset diabetes, as COVID-19 can cause damage to the pancreas, the organ needed to make insulin. Insulin is required to regulate glucose levels. It is important to maintain good control of your blood sugar because high blood sugar levels can weaken the immune system. Currently, there are no cures for COVID-19, so the best measures that you can take is to prevent it by wearing a mask and social distancing. Also, you need to continue to practice food exams as the rates of amputations have increased during the pandemic. If you feel unsafe going to the doctor, ask about telehealth. What do we know about COVID-19 and diabetes? What do we know about disparities in diabetes? The Center of Disease Control and Prevention states that about 34.2 million, that's 10.5% of the US population, has diabetes, with the majority of cases in Native Americans, that is 14.7%, Hispanic 12%, and Black 11.7%. The risk of developing diabetes is 77% higher for Blacks and 66% higher for Hispanics when compared to whites. Blacks with diabetes are 3.5 times as likely to have kidney failure and 2.3 times as likely to have a lower limb amputation when compared to whites. Blacks and Hispanics with type 1 diabetes are less likely to use continuous glucose monitoring, which has been associated with improved glycemic control, than whites. Before we continue, we would like to thank our sponsor, Alpha 2 Omega Youth Services, Inc. We'd also like to thank Dr. Naomi Maria, Tiffany Havin, the Department of Medicine at Northwell Health, the Center of Health Innovations and Outcomes Research, Dr. Dwayne Cumberbatch, our Day One audience members. Feel free to follow us on Twitter at @MinorityHealth3 and on Instagram at Minority Health Conversations. Joined tonight are Ms. Marvani Williams, who is a patient with diabetes as well as a COVID-19 survivor. We also have returning for yet another COVID-19 conversations, Mrs. Constant Brown Riggs, who is a registered dietitian, ebook author of Your Ultimate Guide to Nutrition for Optimal Immunity. And last but not least, we have Dr. Renee Buckman, who is also a nurse educator, service diabetes care and education specialist at Lenox Hill Hospital. I'd like to now transfer it over to Dr. Alison Myers. We'll have a very interesting conversation with our panelists.
Good evening, everyone. Thank you for joining us again. Today, we're focused on diabetes and COVID-19, as November is Diabetes Awareness Month. And I'm lucky to have so many wonderful people today on the panel. So I would first like to start off by asking both Ms. Constance and Dr. Renee, can you explain to us what exactly is a CDCS? So we know that we used to have what was called a certified diabetes educator, but now the Association of Diabetes Educators has made the acronym longer, so I have more words and letters to remember. So now you are a certified diabetes care and education specialist. So can you just start off by telling us, I'll first have Ms. Constance and then Dr. Renee afterwards, tell us what that is and how you became a type of.
Okay, well, a certified, as you said, we were certified diabetes educators first for a very long time. And oftentimes people would think of that, a person holding that credential as just someone that provides education. And the fact is that our scope, if you will, of practice is so much more than simply providing diabetes education. So the name was changed to encompass that. So it's Certified Diabetes Care and Education Specialists, which they felt better represented what we do. Now, in terms of who may be a certified diabetes care and education specialist, it can actually be any healthcare provider. Generally, you will find, I'll say the two most prominent would be registered nurses and registered dietitian nutritionists as well. So those are who will hold that credential more than any other discipline. But it could be physicians, it could be podiatrists, pharmacists also hold the credential as well. So, and first you will have your professional credential in terms of with myself, and I think, I can't think of her name, but I think she also holds the same credential, if I remember looking at the screen correctly, registered dietitian. And so as a registered dietitian, then primarily I'll be dealing, we'll say, from what we call medical nutrition therapy, helping people in terms of their meal plan and that type of thing. But along with it, I have an in-depth knowledge of diabetes and how that would affect everything in terms of the individual. So looking at it from the food perspective, as well as medication, physical activity, and so on. So I'll let Renee comment.
Right. I think we're more collaborative in nature. And also, as my colleague just mentioned, we're not just going and providing diabetes self-management education. We're looking more holistically at our patients. Many of our patients do not have the financial access to medications. So we look at the different resources and put it together a package for them. In the inpatient setting, we also do a lot of teaching, not just to our patients, but to our colleagues as well. So we have established diabetes champions in the hospital setting, and those can be registered dietitians, registered nurses, nurse practitioners, doctors, pharmacists, and so on. And we train them and work with them as they provide a more holistic care to our patients, thus enhancing their um, diabetes and stopping so many return readmissions to the hospital setting. And we want to keep them in the outpatient setting with our colleagues where diabetes can be well controlled and they can enjoy their lives.
Okay, thank you for that overview, both of you. And speaking of being in the hospital, we have Miss Mavrini Williams, who recently was in the hospital because she's a person with diabetes who also suffered from COVID. So Miss Williams, can you tell us your story and your experience of being in the hospital as a person with diabetes and COVID? And just as a side note for all of our listeners, we don't call people diabetic because a disease doesn't define a person. A person's a person. So we will definitely say person or people with diabetes throughout this conversation because we never like to label people by their disease. So Ms. Williams, could you tell us your experience?
Well, how should I start? I know if you should ask me how I ended up there, like I always said, I was moving around, ordinary, doing my daily activities, what I would do. And then I just wasn't feeling well. I couldn't breathe. So I had a doctor's appointment the following day, but my husband insists, you're not well, so you better go to the hospital. So they decided to call the ambulance, and I went there, and they told me that I had pneumonia. So one hospital said they didn't have any space for me, so they had to send me to North Shore. So when I got there, 3 days later, they came in and told me that I had the COVID. And then, at first, from there, I don't know if it's because I was thinking about it, but I started to get weak and then get weaker and weaker. And I find myself sometimes getting in some dark places that I don't know if I'm going to see tomorrow. So I don't know. I really don't know. All I know, I was there, and thank God I'm here today. I don't know if I said sufficient or I said too much. I don't know.
And Ms. Williams, how did having diabetes affect your course of COVID? Was there anything that you noticed that was different in terms of your diabetes? Were your sugars more out of control or anything like that when you got sick with COVID? Did you have to change your medication?
Yes, because at that time I was taking 3 medications for diabetes. And, when I went to the hospital, they decided that they weren't giving me the medication that I used to take. And so they introduce insulin. And there were times when my sugar went down too low, and then at that time it's like at that time really I wasn't eating, so that plays a part in it. I had no taste of eating anything. I didn't want anything. So, and then they gave me the insulin and my blood sugar dropped too low. I began to get even weaker, and then they realized, so I remember this nutrition, she keep telling me, you have to eat in order for the medicine to work. So I tried, but just that appetite wasn't there. So it was like, it was fluctuating. Some days was good, and some days it was bad. I don't know which side to blame it on, whether it was on the COVID or just my body reacting to something that I didn't used to. So they event, I don't even know. All I my mind really, I just wanted to get better. So I really didn't focus on too much of what wasn't happening. I want to feel better. That's the whole setup.
And this was something that we commonly saw, whether it was in the inpatient or outpatient, that a lot of patients, because they were not eating, they were stopping their medications. And unfortunately, because COVID directly affects the pancreas, they still had pretty severe hyperglycemia. So I'll turn again to our experts here. We'll start with Ms. Constance, and then Dr. Renee, you can feel free to chime in afterwards as well. What would be your advice to people with diabetes who are dealing with what Ms. Williams just explained, not really eating much, but still having, pretty severe hyperglycemia with COVID?
Yeah, it's really a challenge when you're not feeling well, you don't have too much of an appetite, but it's really important to understand that once you've taken your medication, particularly insulin, the job of insulin is to bring your blood sugar down. And unfortunately, when you don't have an appetite, you've taken the medication, your blood sugar is going to continue to go down. And that's why you end up having a low blood sugar. Ideally, the ideal situation is that you would have a sick day plan prior to becoming ill. But even more important than that is to understand that you still need to eat. So if you're unable to take food down directly, what we encourage is to drink fluid. It may be juice, the things that we generally tell you not to have in terms of having diabetes, but when you're sick, you need to get some carbohydrate into the system. So approximately 4 ounces of juice every hour to sip on that, or regular soda, something that has carbohydrate or sugar in it, so that it will help to balance that blood glucose so that you don't go too low. So that's one of the most important things. You have to try to get something in. And if it's not solid food, at least take in the liquids, and that will help to balance out that blood glucose level. But as I said, ideally to have a sick day plan prior to becoming ill. So anyone that's listening at this point, what I definitely would advise them is to have that sick day plan in place, speak to your doctor, speak to your whoever's on your diabetes team to help you put that together so that you can be prepared, God forbid, if you do become ill. But it's, as you said, it's a story that we hear so often. You're sick, you don't feel good, you don't want to eat, and you take the medication and you end up having a low blood sugar.
It's important, as my colleague just said, also to do, along with getting something into the system, stay very close to the provider, whoever your doctor is. You need to do self-blood glucose monitoring. That's a must do, at least every hour. And so that when you call your doctor, you can say, I've had this blood glucose, I've taken this amount of insulin or other medications, this is what I have or have not been able to eat, so that they can collaborate with you on a plan of care to stop your blood sugar from going too low or too high. Because sometimes when you're living with diabetes, as I am actually, when you become ill in response to the illness, the blood sugar may go up as opposed to going down.
Yeah, and just as a side note, and I'm not putting Ms. Williams' business out there, I'm just going to say this as a generic. A lot of the patients who've been in the hospital who are sick have also been treated with steroids. So that complicates things as well. So even if you're a patient with COVID who's not eating very much, steroids will make your sugars go up. And that's why for many patients, we do use insulin. So it wasn't that we were purposely trying to drop anyone's blood sugars if they were in the hospital and their sugars went low, but steroids alone will make people's sugars 300, 400, 500. And the best way to get it down is with insulin. And then if you're not eating, Or also if your kidneys are not functioning as well, that can complicate things. A lot of patients who have COVID are severely dehydrated, so their kidneys were not functioning as well as they normally would be, which also can lead to hypoglycemia. And then lastly, as mentioned earlier, a lot of patients in the hospital got hydroxychloroquine. Hydroxychloroquine, although it's not FDA approved for diabetes, it also has been associated with low blood sugars. So for these variety of reasons, we can have ups and downs with blood sugars for people who are being treated in the hospital or outpatient with these medications for COVID. And speaking of the hospital, I want to shift to you, Renee, because you are inpatient. And I was wondering if you could tell us, how was it in the spring when we had our first surge? And what are we looking at now? Is it as bad as it was? Can you give us some information about what your experience has been at Lenox Hill?
Well, back on April the 9th, we had about 320 patients who had COVID in our hospital. Right now, we have 7. So that's quite the improvement. It was a most unusual time for us. We had we moved things around in our hospital as they did in other hospitals in New York. And we had about upwards of 14 ICUs at the COVID peak. It was a very different situation for me as a CDCES, working with my patients, because I'm used to just going into the room, sitting down with them, and us having a nice session. Now I had to go in full PPE gear, which for those of you who have not seen it, consists of a couple of gowns. I didn't even get to wear my own clothes. It was scrubs, gowns, 2 sets of gloves, a respirator, a mask over the respirator, and a helmet that looked like I was welding. And this is what I was going to go and teach in. For myself, I opted to stay. I was given the option of not staying in the hospital setting because I am living with diabetes. I opted to pray, put my stuff on, and go, and I'm perfectly fine. Still, it was frightening. And what was even more frightening was that the patients were aware that at any given time, they could go south, as the kids say it these days. 1 minute they're fine, next minute a patient could decompensate. And I've had patients who would talk to me and all of a sudden would burst into tears and cry and pull at me and say, I don't want to die. As you may have heard, patients weren't allowed to have family members in, they weren't allowed to have guests in, and so they could possibly Zoom or talk on the phone, but that was very lonely for them. And then when our patients would come in and they were very ill, we had to treat them with insulin drips. I'm sure you remember that quite well, Dr. Myers. Patients had to be taken into the critical care areas, treated with insulin drips, be checked completely. And as Dr. Myers mentioned, you're not only treating the diabetes, where the elevated blood glucose makes it so much harder to survive the COVID infection, but then you may have the steroids, and that is making the blood sugars go up even higher. So it was a lot of working together, being very collaborative. My patients that were placed on another site, which is Lenox Hill Greenwich Village, which is all the way down in the village, I was able to see them via Zoom, but my patients that were here in the hospital setting, I saw them in PPE. One other thing about this is that in the hospital setting, we had to prepare many professionals that were not used to working with critically ill patients to work with those patients. And so we had what was known as GNO, or general nursing orientation, every day. So in the midst of working with patients, you are also preparing your colleagues as well.
And Ms. Constance, I know you do more outpatient. Can you tell us about your experience with diabetes and COVID as an outpatient?
Actually, during this time with the COVID, I was not seeing patients at all. Just a little bit of virtual, but not very many patients during that, especially the initial 5-6 months or so.
Yeah, and even though we had the option of doing some things virtually, like Dr. Renee was mentioning, it took probably like a month or so before we would even set up from our health system for me to see my patients on telehealth. So even though telehealth became available, it was not something that we immediately had access to. So it was kind of difficult. And depending on where people work, obviously your office, some offices stayed open, some offices closed early, some offices are still closed. And so I think, there was definitely a variety of access to care for a lot of patients. And so, Ms. Williams, I want to come back to you talking about your hospital. Well, we're still talking about the hospital experience. And one of the things that people, especially people of color, have been concerned about is coming to the hospital as a person of color. Did you have any apprehensions? There had been some talk in our communities that, people of color were dying in disproportionate numbers, so you shouldn't go to the hospital. Can you comment, and especially as you as a healthcare worker, what were your thoughts about that?
Well, like I said, I didn't plan to go to the hospital because I was fine throughout the day. Hospital is a place I don't like, period. So if it was me, like I had to make a decision to go, I wouldn't go. But because my husband was down on me and saying, look, you can't breathe, you have to do something, you're gonna die in here and stuff like that. And I said, okay, I'm at this point where I really can't fight back, so I'll go. But it's not that I wanted to go, because definitely I'm afraid of the hospital. I worked there for many years. And, I'm literally, it's okay when you being like, you are the person who taking care of somebody, but you don't want to be taken care of. So that was like a fear for me. But here I am at this moment. I have no choice. I had to go. So it's not that I go and like something voluntarily. It's not that I wanted to. But while I was there, I experienced a lot of things. Maybe one of the issue was the family member that couldn't come and see you. I don't have a big family, but we are very close. And here I am, I'm lying there. And during that time, my daughter was in Iraq, and all different type of emotion was going on. And so if there was something there to say about women of color or people of color in general, I wasn't even thinking in that area. All my focus mainly was, this is a place I don't want to be. I'm not feeling well. There should be a better way. So I use all my energy, looking in that area. So some people I lost, when I came from the hospital, I spent 32 days in there. When I came back, 4 of my neighbor died. 2 didn't even reach to the hospital. Then, and I'm talking about out of the 4, only 1 person was older than I am. They were younger people. So it's just me in general, don't like the hospital. No matter how, to me, no matter how they polish it or make it look, it's just me having that fear. It's like a personal thing. I had good experience in hospitals and I have bad experience in hospital. But during that time, my focus was, I don't want to be here. I want to feel better. Some days I feel like I was feeling better, and some days I were dying because I couldn't even as much as sit up. So, unless the bed where I pushed that thing and it pulled me up, I couldn't even as much as sit up. And then I was there and they were telling me my kidney was failing. I had to do dialysis, and I said no. So I was actually fighting for my life. I don't know if, it makes sense, but that's where my focus was. So I really didn't see if I was of different color, if I would get better treatment, or I didn't see that. All I see, I want to get out.
Yeah, that's fair. And I think also for you, your experience was also different, probably because the hospital that you went to, North Shore, is an academic hospital. We were doing trials with the drugs like remdesivir, whereas some of the other hospitals in the city didn't have access. I know somebody whose uncle was at another hospital, and you talk about dialysis. At least that was even an option for you. I know someone whose uncle was at one of the city hospitals, and his kidneys were terrible. He was in the ICU for like a week. And I said to the doctor, because she asked me to help, well, why haven't you called nephrology to initiate dialysis? Oh, we don't really have access to that. So I think, being in an academic institution where you do have access to things like dialysis and specialists definitely makes a difference in terms of your outcomes and your experience. And I'm not saying obviously that, every hospital is good or bad, but I think that definitely makes a difference when you're in a hospital that does have access to some of those things. All right, so we have a question in the chat. So I'll turn it over to Maya.
Hi. So somebody in the chat, Josephine, would like to know, is the patient still experiencing any effects left over from COVID? And I'd also like to extend that question not only to the patient, but also to the doctors and and to Connie as well. Are you guys seeing any leftover effects of COVID in the patients that you're currently seeing who had COVID previously?
Ms. Williams, can you start?
There's something with the volume. I know your mouth is moving, but I can't hear anything.
Can you hear me now?
A little.
Okay. Can you comment on whether you're still having any residual symptoms from having COVID?
Oh, no, not right now. I think I'm cleared and I hoped, but right now I'm fine. I'm fine. I took the chest x-ray a couple weeks ago and it was all cleared up. So far I wouldn't say I have anything, there. And my diabetes is like, I would say, back to the normal range before the COVID. So I think I'm fine.
And you're also on less medication after COVID.
If I do what?
I said also you're on less medication after COVID too.
Yes. So basically, uh, it's like a blessing in disguise because I was on Envocana, Januvia, Octos, and right now, and they were like in high doses. And right now, I'm only on Prandin 1 milligram. And so far, I supposed to take it 3 times a day, and I'm only taking it like sometime twice because I use the Freestyle Libra. So whenever I, test the glucose and it's like at a level like under 100, I don't take it. So in that case, I could say the hospital, whatever it is, does something good because maybe I would know of Brandon. Maybe, I don't know. I don't know what was really happening.
Or maybe
So,
you just have a great endocrinologist.
oh, I see. Yeah. So basically, you deal with that type of situation. And, you said, okay, because I remember when I just started it, I don't remember if you remember, I called the office and I said, look, I'm losing my hair because I was blaming it and the Prandin. I was saying this is the new medication, but then talking to people around who had the COVID, they told me that they are losing their hair also. So I figure, well, if the hair lose, as long as the glucose is controlled, I'll wear a wig if I have to. So basically, but that was what it is. It is what it is. But there's something wrong. The volume just get low all of a sudden. So I had to like put the phone up here to really hear anything.
Thank you, Ms. Williams. We have another question in the chat, and that question is, how often should people with diabetes get COVID-19 exams?
How often what?
Should people with diabetes get COVID exams?
Oh, I think that's a question. I don't know. I don't know. I think because, based on the experience I have, I would say that, whenever if you have COVID, there are some symptoms there, because like I said, my day was fine. I woke up in the morning, I was okay. I don't know what happened. But as soon as your body have a way to show you when something is wrong, you start to feel different type of feeling. So since I get out of the hospital, I test 3 times, because they said that, especially now, they said that you can get it again. So I really don't know. To be frank, I don't have the answer. But I think you should test it as often as possible.
Dr. Renee or Miss Constance, would you like to comment on that question?
Well, I would comment that, well, first I'm going to ask this beautiful lady who's been talking, could you tell me when you were admitted to the hospital? What month? Was it like back in April? That ain't bad then, Dr. Myers? Okay, so I think back then the populace on a whole really didn't understand what was happening yet, even though it had been kicking in for about a month or so. I think now the information is out there. If you could possibly be around people who have not been wearing masks, they may be sick. Remember that the masks that we wear, this basically protects everybody else when I put it on, but it does not protect me. So if I'm around other folks without their mask and they are coughing and they are getting sick, if I have placed myself in a position where I could be ill, then I would go get tested. And they have a lot of places that do rapid testing now. CityMD, and I believe our Northwell Urgy Centers, Dr. Myers, they do rapid testing. You should know within a day. And so if you've been around anybody who's ill, definitely get tested.
And I just want to clarify, I think there's a little bit of confusion about what testing is. So there's 2 separate tests. There's the test where they're actually actively looking for COVID to see if you're contagious. That's the nasal swab, as opposed to the blood test in which they're looking for antibodies. So if you want to see if you actively have infection, then you need to get the nasal swab. And as we saw in the hospital, and Dr. Renee can attest to this, sometimes you need to get swabbed 2 or 3 times before you come up positive. The first time they may not actually detect it. So for a lot of patients, when they came in the hospital, especially back in the spring, they had to be swabbed multiple times before we could say, okay, yay or nay. The other tests are antibody tests in which they draw blood from you to see if you were exposed to COVID. So if your antibody test is positive, you're not contagious, because that test, it takes about at least 4 to 6 weeks to come up positive. So I've had people come in, oh, I had the blood test, what do I do? And I said, nothing. It just means that you were exposed to it and your body made antibodies. If you have a positive nasal swab, then you definitely need to quarantine for 14 days and stay away from people. And like Dr. Renee said, it's important that you wear a mask and the people around you wear a mask. I think one of the other questions that often comes up too is, what are some of the things that people can do from a nutrition standpoint to try to fend off dealing with COVID? So I'll turn it over first, Ms. Constance, and then Dr. Renee. Any nutritional tips we can give to our patients with diabetes in terms of how they can try to build up their immune system to try to prevent getting COVID?
Well, of course, as we tell everyone for most anything, is eating a balanced diet, getting vitamin C, and we generally will recommend food more so than a supplement. So for vitamin C, you want to have citrus fruits, bell peppers, strawberries, cauliflower, broccoli, that type of thing. So plenty of fresh fruits and vegetables. Also vitamin D definitely will help as far as boosting that immune system. So you can get eggs. Eggs will provide vitamin D. Also seafood as well as mushrooms are a good source. And then zinc is something else that helps as far as immune system is concerned. And natural sources of zinc would be beans, raw nuts, cashews in particular, shellfish, and nuts and seeds, as well as whole wheat, whole bran will actually have zinc in it. And then vitamin E. You also want to make sure you're getting vitamin E. And that will come also from raw nuts, almonds in particular, sunflower seeds, peanut butter, any nut butter will provide you with vitamin E. And then of course, omega-3s, and that would be your fish. Again, salmon is an excellent source of omega-3. Have fish a couple of times a week. Chia seeds also have some omega-3, as well as canned fish, sardines, mackerel. Those are all very good sources of omega-3. So overall, it's eating a healthy, balanced diet, getting plenty of fresh fruits, vegetables, low on the meat, more, we'll say plant-based, more so than a lot of red meat and animal products in the diet. And all of that together will actually help to support your immune system. And ideally, you want to begin doing that before you get sick, because you want to build it up. It's not something that overnight you can say, okay, I'm going to take this and it's going to boost my immune system. It doesn't work that way. So these are things that you want to be taking in on a regular basis to help begin to boost that. And then of course, in addition to food, it's also being physically active, getting some rest, relaxation, as they say. You may need to do something that will help to lessen stress. So whether it's yoga, meditation, praying, anything to help the body relax, that also helps to support your immune system.
In conjunction with what my colleague just says with regards to rest, turn off your TV, turn off your radio. The election will take care of itself. Do not have these things going while you're trying to sleep. You need to be in a dark room. You need to be comfortable. And if you want to listen to something, I highly recommend putting on something like on YouTube. There's this little thing I sleep to every night. It's just the sound of rain. Yes. You need that rest. That rest is so important when it comes to building up your immune system. And studies have shown that shortened sleep equates with all these out of control chronic diseases such as diabetes and heart disease. So you really want to get that sleep, as Constance just said.
All right, so prevention is key, but what if somebody gets COVID? Any tips? Because we've already heard earlier from Ms. Williams that the appetite is lost. Also, sometimes a sense of taste and smell are lost, which also can contribute to people not wanting to eat. So, you know, unfortunately, if somebody comes down with it, any dietary tips that either one of you would give to a person with diabetes to get COVID this winter?
Well, I will say this, and I got this actually from you, Dr. Myers. We were working on a project. Yes, absolutely. When you don't feel well, be it COVID or otherwise, somehow you just don't feel like cooking. And remember God's love we deliver? God's Love We Deliver is a program, and they originally were set up many years ago for patients living with HIV/AIDS. And now they will deliver homebound nutritious meals for patients with any chronic condition, and diabetes is definitely a chronic condition. So I got that from you, Dr. Myers.
Glad I could be of service.
And then, of course, if they don't feel like cooking, that's one thing. But if they don't feel like eating, that's the other part. Because it can be delivered, but you're just not going to eat it anyway.
Good point.
So, and as I mentioned before, I just want to go back to the point that you're taking, if you have diabetes, you're likely on medication. And if you take that medication and you don't eat, your blood sugar is going to go down. So understanding you don't have an appetite, you may be nauseous. I go back to the fluids again because you need that carbohydrate. And even if it's to get some saltines, as I say, generally we educate 15 grams of carbohydrate per hour. So you can have 5 or 6 saltines. If you can get them in, that's going to be about 15 grams of carbohydrate. If you just can't take anything solid, well, then go for 4 ounces of juice, 4 ounces of soda. We don't want you to drink Kool-Aid under any other circumstance, but if that's what you can take, make it, the Kool-Aid, and that would be about 8 ounces, will give you about 15 grams of carbohydrate. So that's, you've got to keep in mind, it's a balancing act. And, you say, oh, I can't eat, have some ginger ale. Even warm ginger ale, you're still going to get the carbohydrate, but warm ginger ale tends to go down a lot easier. It helps with the nausea and so on that you may be experiencing as well. So that's the key. You don't remember anything else. Remember, if you take your medication, you have to eat. You've got to get something in. Carbohydrate is the primary thing that you want to get in at that time.
Right. And as a side note, a lot of the oral agents with COVID, you can run into issues. So one of the things that happen, as we mentioned earlier, is your kidney function can worsen, and that can impair some of these, that could actually cause problems with some of the oral medications. So that's why I think one of you had mentioned earlier, it's so important that you call your primary care doctor rather than just stopping your medication altogether. Right. So for example, metformin, wonderful medication. A lot of people with diabetes are on it. But one of the problems with COVID is it causes a level of in our blood called lactate to go up, which can be very dangerous. And if you're taking metformin and your lactate is high from COVID, it can be very dangerous that you're not going to get enough oxygenation to your organs, which is why it's not good just to stop your medicine, but to at least call your doctor and have a conversation on whether it's safe for you to continue. The same would be for the new drugs that just came out, which are known as the SGLT2 inhibitors. Those are drugs like mentioned earlier, Invokana. Those drugs work by pulling glucose out in your urine, so they're very dehydrating. And with COVID, you're also very dehydrated. So going back to what's been mentioned earlier, if you're taking that medicine and not keeping up with your fluids, you can get severely dehydrated. So again, yes, you need to take your medicine, but you also need to have a conversation with your doctor, because if you're severely ill, there may be a reason for you to make some adjustments in your medication. So please don't just stop it. Don't just keep taking it. Call your doctor. That's the most important thing that you can do through this process. Okay. And then sorry about that. So then I think just, to wrap up, since we're getting close to the end of the time, I just wanted to ask the panelists, do you have any last comments or thoughts for the audience in terms of diabetes and COVID? I'll start with you, Ms. Williams. Any tools that you want to share with us, our audience, before we close up? Ms. Williams, can you hear me?
Yes. What you said, if I have any comment?
Yeah, any final last tips or jewels that you want to share for our audience about having COVID and diabetes?
Well, the only thing I would say is that just listen to your body, because your body will speak to you whenever something is wrong. And then the other thing, listen to your doctor. And as I was listening to the other lady, she was saying that you know, speak to your doctor if you feel, certain ways. And as I share with you, Dr. Meyer, how my doctor, I couldn't find him during my time, so that's why I was here laughing. It's like I was on my own. I just tried to think, okay, maybe this is working, maybe this is not, because Dr. Goldman was nowhere to be found. So it's like, actually everything I had to rationalize it and say what to do and what not to do, until, thank God, maybe, he have a way of working things out. I found you, Dr. Meyer, and then you introduced me to this doctor now, Dr. Marler. She seemed to be somebody who I could reach out to. So for the audience, I would say, make sure you have a doctor that you can reach and they can reach you, because there are a lot of times when we really don't know what to do. It's like you're most focusing on what is going on in your body, and not you don't even see anything else. So just keep in touch with your doctor. That's it.
Thank you, Ms. Williams. Okay, Ms. Constance?
I would say, please have that sick day plan before you get sick, and that will help to eliminate some of the problems that you may experience. Because whether we're talking about COVID, or we're talking about the flu, or any type of illness for a person with diabetes, can actually turn into something so much worse. It may be even the common cold. So it's a good idea, particularly when we think of COVID, that you do have that sick day plan in place prior to getting sick. And that's for any illness. And the doctor, your diabetes educator, whoever your healthcare professional is that you're working with, they're going to tell you exactly what to do, when to call them, what your blood sugar should be, how to treat, the low, how to treat the high, all of those things to watch out for. Your healthcare provider will give you that information, and that will help to make the illness a little less stressful. You still may feel bad, but at least you're going to have these steps and you're going to know what to do, so you don't feel alone.
That makes sense.
Dr. Renee?
Yes, well, in conjunction with what everybody else said, especially about having the plan, I think one thing those of us living with diabetes have got to understand is that when you get ill, your medications may need to be changed. And so having that plan, but getting that provider that you can find when you need them, get them on speed dial, so that you have the ability to reach out to them and say, this is what's happening with my blood sugars, this is how I feel, and they can collaborate with you on a plan of care to keep that blood sugar down so that you don't get worse.
Thank you. We actually do have a question that's sort of like a follow-up, and that is using what Miss Williams just said about that she couldn't find her doctor when she needed the doctor. Should we have a conversation with our doctors to determine how or who to reach them, who or how to reach them if we get COVID?
Yeah, you trying to get an answer about the doctor?
Well, I was asking the physicians, like everybody on the panelists. It's basically like you mentioned, we do not have you could not reach your doctor. So the individual wants to know, should we be having conversations with our doctor in the event I get COVID-19? How can I reach you, or who should I get into contact to be able to create like the sick day plan?
Yes.
Oh.
Definitely. And that's one of the purposes of that sick day plan. It will, tell you who to reach out to, when to reach out to them, what the emergency numbers are. It will, you have all of that information within that plan. So absolutely speak to your physician before you get sick.
And I think also that plan is not only just if you get sick, but also like if you're having any surgeries or procedures when you go to the hospital, it's always good to have a conversation, whether you're having just a colonoscopy, a biopsy. You probably will need to make adjustments to your medications because they will not allow you to eat. So that's also another time when it's really important to reach out to whoever your diabetes provider is, whether it's you're seeing a diabetes educator or seeing an endocrinologist or a primary care doctor. You should always have a conversation, because sometimes you might not get proper guidance when you go for your pre-surgical testing. So I would say another time when you need to have a plan, just like a plan.
Part of living with any chronic condition is staying close to your provider. So a lot of times, guilty as sin of I'm feeling fine, so I guess I can skip this visit because I have my own patients to see. No, it doesn't work like that. You have scheduled visits to see your provider, regardless as to the way you feel. You need to keep that visit. You really do.
Thank you. And I'll just slip in one more question. We have like 4 minutes to go. Somebody on Facebook wanted to know, like, as individuals with diabetes, what are the signs of high potassium?
Okay, so did they say what the context was? Because high potassium can happen to anybody. Was there something in particular?
No, he just asked, what are the signs of high potassium? Signs
Okay,
of high potassium, yes.
Okay, so when people with diabetes, they often take medications to maintain their blood pressure and also to protect their kidneys, which are called either ACE inhibitors or ARBs. So those medications as side effects can raise the potassium. And also sometimes people just have problems with their potassium because they have kidney failure. So when your kidneys are not functioning well, when they're at like 20 or 30% or less, you often can't handle your potassium load very well. So that can also make your potassium go up. So the most worrisome thing about having high potassium, whether you have diabetes or you don't have diabetes, is the fact that it can cause all types of abnormal rhythms with your heart. So if somebody was having palpitations, that could be a sign or a symptom of high potassium. That's probably one of the most concerning things, like I said, is the effect of high potassium on the heart. Some people may not even feel it. I've had some patients who come in, you check their blood and you just happen to catch it. But sometimes people can feel, like I said, heart racing because they have abnormal heart rates. But again, this can also happen to people without diabetes.
Thank you. Okay, so we are at 8:57. So I guess I have to fill the big shoes of Dr. Myers to try and close up. But before we do that, I just want to share my screen to just share that Miss Constance Brown Riggs, she has this free ebook called Your Ultimate Guide to Nutrition for Optimal Immunity. You could sign on to her website, that's Eating Soulfully, and you could sign up for free and be able to download this website to get a guide on how you could help with immunity in terms of your nutrition. With that said, I would like to also share the key takeaways at the event for this event tonight. I learned something new, that you should not call individuals diabetic because they're not defined by the disease. So you should say a person with diabetes. Whenever you get diabetes, whenever you feel sick, your blood sugar levels are low, it is good to have at least 4 ounces of juice. And that is the only time that you're allowed to drink juice, the only time you're allowed to have Kool-Aid. And you should get a sick day plan. This sick day plan should be prepared before you become ill. So you should talk to your doctors long before you fall ill. Also, a question was asked about what do people with diabetes need to do in terms of how often should they get tested with COVID-19. If you believe that you have been in contact with somebody with COVID-19, then you go ahead and you get the test. There are 2 types of tests. The first one is the nasal swab, which you believe that you're in contact. This is when they push the thing that looks like the cotton in the nose. And then if you could also have a rapid test, and then you'll find out whether or not you have COVID. And a blood test does not determine that you have COVID-19 now, but it's that you probably had COVID-19 previously. If you do have COVID-19, when you do the nasal swab, you stay away from people and you quarantine for at least 14 days. In terms of what to do for nutritional tips, you eat a balanced diet, and that's in terms of prevention. Your balanced diet should contain vitamin C. They advise that you eat more food than supplements. You have vitamin D to boost your immune system, and that could be eggs and mushroom. You also need to get zinc, which is peas and beans and raw nuts. Also, you need vitamin E. Any nut butter will get you vitamin E, and omega-3, which you could get from seeds, fish, chia seeds, and sardines. You have to eat more of a plant-based diet. In terms of now, you also need, physical activity and plenty of rest. Turn on your TV and turn off your radio. You could also use YouTube to get white noise, which is rain, or you could have, traffic in the background or whatever, like a fan blowing or an AC on. YouTube is very good for that. Resting is important, so you make sure that you get a sufficient sleep, whether that be 6 to 8 hours of sleep on a regular basis. When you get COVID and you do not feel like eating or you cannot cook, you should check God's Love We Deliver. They'll be able to deliver nutritional food for you. And if you cannot eat, remember that if you do not take your diabetes medication, then your blood sugar level will go down and you will fall sick. So again, the two things that you need, you have your sick day plan prior to, you talk to your doctor and let your doctor know what should you do in the event that you have COVID-19 or you have a procedure that you need to do. And you also go to good old ginger ale. Warm ginger ale is very good, and you drink your Kool-Aid. You also, the gems of the takeaway from the panelists is that you listen to your body, listen to what your doctor has to say, have a sick day plan, and speak to your physician on a regular basis. And last but not least, our next event will be on November 19, and we'll be talking about small businesses part 2. In December, because it's the holidays, we want to do an event on grief. Our first event will be on December 3rd, and that will be in English, where we'll be having mental health professionals talking to us about how to deal with grief, because some of us might not have our loved ones during that time. And on December 17th, we also have a grief session, and this session will be in Spanish, dedicated to the Hispanic population. And that's about it. So thank you very much, everyone, for joining us, and we will see you on November 19th. Bye.
Bye.
Bye-bye.
Bye-bye.